Good afternoon, everyone. My name is Shannon Simpson, and I am here today to present my research on the effects of an integrated core and Pilates training program on upper and lower extremity Y balance test scores in recreationally active adults. So for background information, balance training has shown to be effective in the improvement of static and dynamic steady state, proactive, and reactive balance. As adults, the aging process can cause changes in the sensory motor and neuromuscular systems, which can negatively affect performance, static and dynamic postural control, and increase the risk of injuries and falls. Furthermore, injuries and falls can create additional issues, including mobility limitations, functional decline, and dependence on care, which can significantly reduce the quality of life in these individuals. That being said, core and balance training could have a potentially positive effect on decreasing those effects of the aging process, which leads to the purpose of the present study, which was to investigate the effects of an integrated core and Pilates training program on upper and lower extremity Y balance test scores in recreationally active adults. This study was a randomized control design based on research previously done by Dr. Grayson Elmore, who used this program to investigate integrated versus Pilates-based core training in collegiate dancers. In this study, the independent variable is the effect of the integrated core and Pilates training program on balance test scores, with the dependent variable being the balance test scores. Participants that were recruited were healthy adults, recruited from Anytime Fitness Fairfax, using word of mouth and the social media platform of Facebook. A total of 39 participants were recruited, with 25 females and 14 males at an average age of 45.4 years old. Following recruitment, participants were randomly assigned to the experimental or intervention and control groups using Microsoft Excel, with those numbers shown here at 21 and 18. Inclusion and exclusion criteria was determined using a criteria questionnaire. Participants were to be considered recreationally active, meaning they had been physically active within the last 3 months for at least 2 days per week for at least 30 minutes per day. Participants were to be excluded if they were pregnant, if they had sustained an upper or lower extremity injury within the last 3 months, or if they had a condition preventing their ability to perform the balance test or the intervention program exercises. During recruitment, no participants were excluded, and all participants agreed to the time commitment involved in both pre and post testing, as well as the intervention program sessions if selected. So to show the demographics of the participants here, age, height in centimeters, and weight or mass in kilograms are shown here, with the left table showing the participant pool as a whole, and the right table splitting the demographics up by group. Following the recruitment and selection of the participants and their group assignments, pre-testing occurred, and the same test was used for both the pre and post-testing. Before administering the test, height in centimeters, mass in kilograms, and limb length in centimeters were measured. Limb length was measured for the upper extremity from the C7 vertebrae to the tip of the middle finger, and the lower extremity measured from the distal ASIS or the hip bone down to the medial malleolus. While the study planned to use the Y balance test, the resources were not available. So a modified test was used, as you can see in the photo, which this is typically referred to as the STAR excursion balance test. For the sake of this presentation, I will continue to refer to the test as the Y balance test, although as a branded product, that is not what was used. Continuing on, I, as the administrator of the test, demonstrated the positions for each direction, so medial, inferolateral, and superolateral for the upper extremity, and anterior, posteromedial, and posterolateral for the lower extremity. Following 3 practice trials in each direction, 3 measurements were recorded. So this slide here just shows the directions for completing the lower and upper extremity reaches. This is what the actual Y balance test looks like. And as I mentioned earlier, we used a modified version. So just so that you're familiar with those terms and what they look like. Once pre-testing was completed, the 8-week intervention program began. 21 participants were selected for the program, which consisted of one 30-minute session per week for all 8 weeks. Each week, I, as the trainer, administered the same warm-up of 7 exercises for 2 rounds of 30 seconds each. Following the warm-up, I demonstrated the 4 exercises for that week and explained the format for the session. On weeks 1, 3, 5, and 7, the exercises were performed for 2 rounds of 12 repetitions for each round. And this format focused more on endurance, whereas weeks 2, 4, 6, and 8 were broken down into 4 sets of 6 repetitions, which had more of a focus on strength. And for the single exercises, the number of repetitions was completed on both sides. As you can see on the right here, these are a couple of the images from the first week of the integrated program showing which exercises were to be completed. Every 2 weeks, the exercises became increasingly more challenging. The exercises started from a supine or prone position, so lying on the back or the stomach, to a quadruped or an all fours position, to kneeling, and finally to standing. Along with this, resistance bands and balance discs were introduced throughout to increase difficulty of the exercises. So following the intervention program and post-testing, the data was input into Microsoft Excel. Averages for each direction of the upper and lower extremity tests were taken, followed by a calculation of the found average divided by the participant's limb length and multiplied by 100 to be shown as a percentage. This calculation was done for both the upper and lower extremities, for the right and left sides, and for the pre and post tests. From there, the combined change scores for both the upper and lower extremity were calculated. So the right and left sides were combined into one score, and then the pre-test score was subtracted from the post-test score to get that combined change score. After processing the data, statistical analysis took place using the statistics software Jamovi. 2 separate ANOVAs, or analyses of variance, were calculated for both the upper and lower extremities. First, a 4-way repeated measures ANOVA was conducted, with the between subject variables being the control and intervention groups, and the within subjects being the time, pre and post, side, right and left, and direction, which were the 3 reach directions that were shown earlier for each of the tests. Additionally, a 2-way ANOVA was also conducted using the found combined change scores to compare time from pre to post test and group from control to intervention. So as shown here, this is the image of the 4-way ANOVA for the upper extremity Y balance test, with the y-axis being the percentage of limb length and the graph showing time, direction, and side. So visually, you can see here that there seems to be no drastic improvements in either direction, positively or negatively, for either group between pre and post test. And that's very similar here with the lower extremity too, the y-axis representing the percentage of limb length, showing the side, time, and direction. No really significantly different scenarios between pre and post. So then the next 2 slides show those combined change scores with a violin graph for the upper and lower extremity, which again were separated by time and group. And as you can see here, this is showing more of a difference between the groups, with the intervention group showing a greater improvement than the control. And with regard to the lower extremity, the y-axis does have a wider range than that of the upper extremity graph. So the plots do look closer together than that of the upper extremity, but still show a pretty big change for the intervention group as well. So our big idea was to see if these 2 groups were different. In the 4-way ANOVA, groups did not look different, which is evident based on the images just shown and their higher p-values. However, there was a difference across time in both the upper and lower extremity. So generally speaking, on average, all the participants improved from pre to post test. Therefore, we decided to look at the combined change to understand whether there really was a difference in the change scores between the groups, which is why we conducted that 2A ANOVA, looking at the change score. And the intervention group's participants' combined change scores improved by a mean of about 10.3 plus or minus 7.4% for the upper extremity and 12.7 plus or minus 10.1% for the lower extremity, which, as you can see on the right side of the screen here, is much higher than that of the control group. So as stated in the previous slide, while the participants improved from pre to post, it was more evident in the combined change score calculations that the intervention group had improved following the training program. The reason for the finding that both groups improved between pre and post test could be that the participants knew how to complete the test the second time, so being more familiar with the process allowed them to achieve higher scores. Also, both the control group and intervention group were not instructed to change their exercise routines outside of testing or training sessions for the research. So the control group could have been exercising just as regularly as the intervention group, if not more, which could be why the initial calculation showed no extreme changes from pre to post when it came to side, group, or direction. According to previous literature, core training programs have shown to have had a positive effect on strength and improving dynamic postural control, which is in alignment with the findings of the present study. And multiple studies have found too that providing a core strength training program increased reach distances for test directions for intervention groups compared to control groups. And one interesting aspect that I'd like to point out is that I did receive reports from multiple participants that indicated a feeling of improvement. And while I did not take specific subjective measures after receiving a few of these reports, I was inclined to send out an anonymous exit survey to the participants in the intervention group, as I was curious of their answers. And many participants stated that they felt more flexible, stronger, more aware of their core, and that the program had assisted in getting them back into a normal routine of exercising. So overall, I found that to be another positive finding from this program, although I did not include specific measures in my research. Quickly going over a few of the limitations that I had, the selection was a convenient sample because I did not have access to many groups of people during this time. I originally stated that the age range for the participants was to be 22 to 65, but I did have two participants slightly out of that range, with one being 21, about to turn 22, and one just having turned 66. Because of the COVID-19 pandemic, I ran into a few other obstacles, including the fact that I originally planned to use this program on collegiate dancers, as Dr. Elmore did, but I did not have access to this demographic. And because of the restrictions and limitations of the pandemic, equipment had to be distributed to each participant individually. And the facility, Anytime Fitness Fairfax, who graciously allowed us to conduct this study, only allowed for 5 participants in the training area at one time to practice social distancing. Therefore, 5 sessions per week were offered to the participants in order to provide 30-minute sessions that all participants were able to consistently attend. As a practitioner who has trained in both a group setting and an individual setting, as well as being the certified trainer who conducted these sessions, I would agree that as a broad statement, core stability and balance training is beneficial for this age group. I saw the effort that these participants gave to the program, and they became increasingly stronger and more able to perform the exercises as time went on. This aligns with the purpose of the program on adults to prevent falls, reduce risk of injury, and improve flexibility and mobility. This in turn also goes along with proper exercise technique, because many exercisers aren't necessarily aware of the importance of using their core during most exercises, where proper form does include the engagement of the core in order to stabilize the body for whatever movement pattern the individual is performing, which can be very important. So as a conclusion, the integrated core and Pilates training program was beneficial to the participants and in a practical setting would be beneficial to practitioners as an effective training program requiring minimal time and equipment, and to clients and patients as a supplemental training program to their own exercise routines to increase static and dynamic balance, increase joint mobility, increase core stability, and to decrease the risk of injury or falls. Future research does need to be done, as I feel that investigating the benefits of increases in specific reach directions could show more narrow results. But more importantly, I feel that administering a survey along with the program would be really beneficial to understand how participants felt throughout the program and following its completion. And with that, I'd like to conclude my presentation with my references and open up the floor to any questions you may have. Thank you.